Good morning, everybody. I'd like to welcome you to the fourth of our webinars on insights from smokers, and this one is focused on healthcare professionals as well. Hopefully you will have caught one or more of the previous sessions that we have run, but for those of you for whom this is the first time, we are sharing with you insights that were commissioned, insights work that was commissioned from us from DHSC. The focus was on disadvantaged smokers and on healthcare professionals, and we were looking at the attitudes and behaviours that were linked to the pandemic, to the cost of living crisis, and then just more generally around smoking and opportunities to help people quit. So the previous sessions are all up online and available if you haven't managed to catch any of them, and we'll circulate the links after today's webinar. But without further ado, I'll just run through the agenda. Hopefully, let's just turn it into a presentation. So I don't know if I introduced myself. I'm Deputy Chief Executive at ASH. I'm Hazel Cheeseman. And we're shortly going to hear from Sonya, who has been steering us through this series of webinars, who's the director at Bluegrass, who undertook the insights work for us. And as I say, today's focus is on the perceptions of healthcare professionals. And once we've heard from Sonya, we will have a response from a GP and a response from a pharmacist to help us frame the conversation that we'll then have with everybody. So really pleased to be joined by Dr. Alex Bobak, who's a senior GP partner and a long-standing ally in the campaign to end the harm from smoking, and an equally long-standing ally in Darush Attar-Zadeh, hopefully I said that right, Darush, who's a respiratory lead pharmacist. So we'll hear from both of them. Please put lots of questions and comments in the chat, and there's been lively chats throughout the last three webinars that we've had, and lots of the conversations that we've been having in the previous events have touched on the issue and the role of healthcare professionals, so it will be good to come back to some of that today. Right, a bit of housekeeping, whoops. So it's being recorded. The recording will be circulated afterwards, as will slides, particularly Sonia's slides. Anybody who's not speaking should keep themselves muted, and as I say, please kind of be lively in that Q&A in that chat, so that we can have a detailed kind of Q&A discussion later. And if you've got any technical issues, pop it in the chat or email the admin inbox. Right, I think I will stop there and hand over to Sonya to take us through the first of our set of insights. Thanks, Sonya.
Thank you, Hazel. Okay, this is the bit that scares me most of all. I'm going to try and share the presentation. Let's see. So how is that looking for everyone?
I can see it.
Brilliant. Okay. So yeah, thank you, Hazel. My name's Sonya Dixon, and I am a director, as Hazel said, at Bluegrass Research. And we, as Hazel said, we've done quite an extensive bit of work for ASH recently. And this presentation draws from that wider research project. The project focused on disadvantaged communities, and on the right is a list of the profiles that we were looking for. But this particular presentation focuses on a number of depth interviews that we undertook with healthcare professionals, and there's a list there. So we spoke to community pharmacists, and we were interested to speak to mental health nurses in primary care settings, recognising the fundamental and intricate link there is between mental health and smoking. We spoke to some practice nurses and some GPs. So no more than one healthcare professional came from any one practice, so there was a good spread there. They came from across England. We had urban practices, suburban, rural locations, and we were in London, the North East Yorkshire, South West and South East, so quite a good spread there. We skipped the Midlands by the looks of things. Catchment profiles in terms of where the practices were located included some that had very culturally diverse communities, Lots of we spoke to we spoke to practice in Leeds, for example, where there was a lot of students, high levels of transiency. We spoke to some traditional market towns, practices, and a good number were in highly deprived areas. So what we want to look at now is just the sort of the counterbalance to all the work that we saw with smokers, is to look and see what is the view of these healthcare professionals around smoking. So first of all, just to sort of discuss the context, there was very mixed levels of smokers across the practices that we spoke to, and typically practices where there were higher proportions of deprived patients or older patients saw greater rates of smoking. One practice nurse estimated that up to 3 in 5 of the patients that she saw smoked. Mental health nurses also felt that they were seeing, you know, a higher proportion of patients that smoked than they would necessarily be in the general population. And as we've said, we know that mental health issues and smoking, oh gosh, go hand in. That wasn't very clever, was it? Right, let's go back down to where we were. Oh, sorry.
Do you want one of us to share your slides, Sonia, or are you okay?
Can you see these?
Yeah.
You can, okay. So let me just make that. I think I just pressed the wrong button there. Right, so there we are. Yeah, so we want to look at the attitudes of healthcare professionals. Sorry, I've been knocked off my stride, but I'm going to get straight back into it. So the one thing that came out quite strongly across all the different profiles of healthcare professionals that we spoke to was that most felt that tackling smoking was a priority and is fundamental in looking after the individual, regardless of the nature of the visit, if you like. So in terms of the holistic approach to an individual's well-being, health and well-being, smoking is very much a priority. Some feel it's the priority for improving the health of a smoker is to tackle their smoking, but there were comments that actually questions are asked about smoking just as part of ticking a box somewhere on some form, or you know, to meet some performance requirements. So there's a quote here from a doctor down in Somerset. It's pretty much still up there. I think the impacts of smoking are so clear that it's still a big thing for those who are still smoking. I think in terms of improving your health, if you're a smoker, then there's not much that's going to top it, really. So an indication of the priority that GP particularly puts on smoking. Just more context for what we're looking at here is that COVID has had a lot of impacts, as you will all be aware, on the ways of working. So doctors talking about not seeing as many patients in person. Some can see the positives, some can see the positives and the negatives. So definitely an impact on the way of working for these healthcare professionals, but also on services offered. So we heard about services that were halted through COVID by necessity, but haven't necessarily been resumed. And I'm particularly thinking about, there was a respiratory clinic in one of the GPs that we spoke to, and they said that hasn't picked up again yet. And also important is this new sort of positioning, if you like, of the pharmacy. That there is very much, and this is something we see through a lot of work we do, people talk a lot more about pharmacists as part of their resource for getting support for health and well-being, a greater awareness of the offer beyond prescriptions and supply of medications. So when we looked first of all at how these different healthcare professionals raise the subject with patients, then I'm not going to surprise anybody by saying that time was the big barrier for GPs. And we did have a comment that actually if it wasn't directly relevant, then talking about smoking would be the first thing that would go. It's not something that they can prioritise when time is particularly tight. And there's a quote there: "It depends on the condition they're coming to me about." So I should link more of it to mental health, but I probably don't. I think if I'm being honest, the way our workload is at the minute, particularly in the practice I'm at, and the way our appointment structure works, we're very much putting sticking plaster over things and trying to move them on, and we don't have much by way of continuity of care. That relationship is quite difficult, and I think we could be doing a lot more if we're not run as run ragged, to be honest. And I suspect that that's a feeling that will be quite similar across the GP board. So an indication that it's not something that seems important, but actually it can fall down the priority list. GPs told us that they typically raise the subject on a patient by patient basis, and there are things that might trigger a discussion about smoking. So a diagnosis of a related disease, which is seen as a teachable moment. If there's other illnesses present that might interact with smoking, or patients who, for one reason or other, need to make lifestyle changes, then tackling smoking is brought up as part of that. The nurses that we spoke to said that they quite often ask about smoking as part of a template, and they didn't mind that. They quite enjoyed the fact that that normalises conversations, and very much it's the case that people said that it's expected of them to ask about smoking. It's not that it's a surprise when it's brought up with patients. But they're saying, regardless of whether it's part of a template or not, most of them would raise the subject of smoking, and if they know that a patient is a smoker, they would have an ongoing conversation about that, about smoking with that patient. Pharmacists said that it works both ways for them. Sometimes they're approached for help, but actually the pharmacies that we spoke to, the pharmacists were saying that they do take the opportunity to proactively address the issue if a patient comes in with a cough, or if they're part of the blood pressure service, or if they're looking around nicotine replacement therapies, then they will try and engage that patient or that customer in a conversation about it. They talked about their role as being partner to their patients in the management of their health, and they talked about the remit of reducing health inequalities, and they see smoking as very fundamental to that, and very much talking about that empathy, support and understanding. And I suppose what's interesting about the pharmacies as well, and pharmacists particularly, is that they have a commercial hat on as well, so they recognise that patients don't have to come into their pharmacy, so there's that to balance for them as well. Smoking seems important in regard to the new medicine service that they're providing, because it's so closely linked to some of the diseases that are part of that programme, and so discussions about smoking quitting are seen as very significant to that new medicine service. I would need to at least mention it, and I usually ask what their thoughts are about it before I go any further. It's part of the medicine review. It'd be something I would need to discuss with them, so I'd need to document it and make sure I have an up-to-date status because some records aren't up to date. So there's a pharmacist there in Newcastle discussing how he would approach it. Talking to mental health nurses, they very much feel that mental health patients need to be treated differently to other smokers, and that it's all about treading very careful, and the priority is that the patient is safe. However, that said, whilst they wouldn't necessarily address it at a moment of crisis, they would very much address the topic of smoking and quitting smoking at some point in the relationship. They don't see it as part of their role to offer advice on that process. They tend to refer on into services elsewhere in the community. And they recognise that smoking is a very important day-to-day tool for getting through life for a lot of mental health sufferers. So they feel that the focus should be on ensuring the patient is engaged with appropriate support before starting a quit attempt. So there's things that need to be put into place for mental health sufferers before they actually are prompted into the quit attempt. They talked about also considering factors that are particular to a mental health patient, for example, when talking about quitting and suggesting and helping to shape the right support. So it might be that these patients are very isolated and have a lack of support network, or reduced cognitive ability, or things such as, you know, not recommending group sessions because they don't like to be with other people, or trying to organise something that might be online because the patient might suffer from agoraphobia. And there's a quote there from a mental health nurse saying, if there's someone with mental health difficulties who's wanting to give up smoking, and that's something that they have used as a coping strategy for their mental health, then I think it needs to be that we should make sure that that person is in a really secure situation in regards to their mental health, and they're feeling well per se, or good family support or whatever, or actually that person is linked up with the right mental health services as well. Because, you know, if they've nothing to turn to in terms of their usual crutch, then they need to be able to support it in terms of developing healthy coping strategies that aren't going to impact on their health and life length. So in other words, these patients use smoking to help them get through things. If we remove that crutch, we need to be able to give them something else that will service them in a healthy way to cope with their stresses. When we talked about handling the conversation about smoking, there is a perception out there in the same way that people feel that smoking is very important to a holistic health approach, that you're actually doing patients a disservice if you don't ask and don't have the chat about smoking, and that regardless of what the patient's reactions are, the care provided shouldn't be influenced by that there should be an approach to delivering advice about quitting, regardless of where the patient is. I've mentioned already that several healthcare professionals commented that their patients are fully expecting to be asked about smoking and to have that discussion. I think it's one thing raising the question, do you smoke? Where are you in terms of quitting? But having an ongoing conversation, we found that some healthcare professionals were less comfortable and find it much harder when you've got more entrenched smokers, heavier smokers, longer standing smokers who are more resistant to the quit message. And there was comments from a few that they felt that some patients had had less positive experiences with healthcare professionals before, and that can mean it's a more difficult conversation to have. And something that's worth saying at this point, that when we talk to all of the smokers that we spoke to in this wider project, there is some resistance to talking to GPs about it. There's a feeling, I remember one guy quoting, you know, you can go with an ingrown toenail and then blame it on your smoking. So there is a feeling that they are blamed, that it's a judgmental approach that's taken, so that some smokers are quite reluctant to go to healthcare professionals for help. That said, many healthcare professionals we spoke to said that the emphasis is about being in partnership with the patient, not judging them, not pressuring them, you know, to lay out the reasons to quit, lay out the options available for support for quitting, and then leave the decision to the patients. And it's about understanding. It's about understanding where the patient is with their mental health, what their personal situation is, and what their previous experience of quitting is. So it's very much about taking the individual and understanding their situation and trying to help from that point. But all of that said, there is a feeling that you have to be pushing an open door, that if someone doesn't want to quit, then there's nothing you can say or do to persuade a smoker who isn't ready. And, you know, I can see how that would be the case, having tried to have, you know, in-depth conversations with smokers about quitting who just aren't in that space. They're just not interested in quitting. Interestingly, that all the GPs that we spoke to, and we had the conversation with practice nurses as well, they advise cutting down as a route to quitting if they feel that the patient doesn't perceive that quitting itself outright is an option. Nurses and pharmacists agree that it's good preparation for a quit attempt, but there is a debate there about actually what we want is people to quit, not just to reduce, and it's too easy to make some reduction and then feel you've succeeded. So it's an interesting variation in approach across healthcare professionals there. In terms of what's available locally to support quitters, it's just such a fragmented picture. Healthcare professionals know to varying degrees quite what is out there. Some work on hearsay. They don't necessarily know a lot about what's available. So they might know the pathway, but they don't necessarily know what's at the end of that pathway, if that makes sense. Everyone we spoke to had a different situation in terms of whether they could offer support services in-house, whether they could prescribe NRT, whether they could refer to different people where it was they referred. It was a very changing. We spoke to some GPs who said, well, I used to be able to prescribe things. I don't think I can prescribe things now. Very changing, very fragmented and very confusing. When asked about what the ideal would be, there was a number who felt that in-practice support was ideal because patients, a lot of the patients that they see are regularly coming into the practice, so there's some comfort in being in that environment and knowing the people potentially, but certainly the building, and being used to visit there, not having to go to somewhere new. A number questioned the quality of the local provision, both questioning in terms of saying, I don't know what it's like, but also some have had perhaps less than positive feedback. And sort of ultra local was seen as the ideal by a lot of healthcare professionals, so literally in the community rather than just necessarily in the wider area. Pharmacists who haven't been commissioned to deliver smoking cessation services, you know, so question how they can actually meet their requirements to address health inequalities if they can't then tackle that particular issue, which they see as fundamental in the picture of health inequality. Lots of different healthcare professionals saying it's quite hard to manage patient care properly when you can refer them on into a service, but you have no feedback as to what happens, whether they go, what the outcome has been, or how things are progressing. You know, that leads a bit of a void of information for the GP particularly, but also other healthcare professionals. I know that we have a text message that we send to people that they have to contact the service, and I don't know if there are any issues with that. So there's a first stumbling block. Not sure if that text message is even getting through, but I know that we can't persuade, we have to refer there. I can't provide stop smoking meds. I have done before, but not at this surgery. So as I say, sort of a slightly frustrated feeling there, that even if you felt you had the capacity and you wanted to help, then actually the infrastructure there isn't there. In terms of prescribing NRT, mixed reports of whether people could prescribe NRT medication and therapies. Some pharmacists were independent prescribers, and they talked to us about this, but it didn't seem from our point of view that this meant the same thing for all. So, for example, one pharmacist could prescribe NRT, but it would cost the patient. Another can offer medication as part of the service they're commissioned to deliver, and a third can't prescribe stop smoking therapies despite being an independent prescriber. So a mixed picture even there, just amongst pharmacists. Similarly, mental health nurses didn't all have the same prescribing powers. Practice nurses talked about situations where their GPs could and couldn't prescribe. Some commented about the whole concept of providing free NRT, and a lot of our smokers have talked about that in the past, and then now healthcare professionals agree that it's a barrier to quitting for some smokers. That, you know, if money is an issue for dropping smoking, then having to pay for NRT is a barrier there. In terms of vaping, really sort of a bit of a hot potato. Really, I'd love to go back to these people now and talk about vaping now that that new study has been released recently. A lot of uncertainty about advising or prescribing vaping as a quit aid. Talking about the fact that the products are unlicensed, unregulated, and feeling that they have a duty to advise the patients on that, and that it would be irresponsible to just tell them to go off and try a vape. There's a feeling amongst quite a few of the healthcare professionals that we spoke to that evidence isn't there, or there's not enough evidence to reassure on the safety of vaping. But people were saying it seems to be less harmful, but we can't be sure of that, and therefore that is a sticking point for us. And that leads to a reluctance and a caution to prescribe or advise amongst most of the people we spoke to. also a concern that vaping can aggravate some existing conditions. Some refer to more specialist advice if they're asked about vaping because they feel unequipped themselves. One commented that patients themselves are wary about vaping, and that's very much something we see with smokers, not all by any means, but certainly some. And personal opinion experience can influence both ways. So if you've had experience yourself possibly of vaping and coming off, you know, quitting smoking via vaping, then that can influence what you do. I'm skipping these quotes because I'm aware that time is marching on. We talked briefly about training to the healthcare professionals. Again, a very sort of mishmash of what training have people had. So initial education typically has some training about smoking in it, but otherwise training is typically linked where there's been a commissioning of stop smoking services. So for example, where a practice or a pharmacy is being commissioned, then relevant staff are trained, but not necessarily those who aren't, who are within the practice but not directly involved with delivering the service. People in secondary care or who've worked in secondary care and will possibly more likely to have seen training. But none of the practice nurses we spoke to had received any relevant training within the past 10 years. Some had never had any. None had received any training on vaping. You know, lots of different things going on there. Patchy training amongst GPs, again, none about vaping. One mental health nurse received regular training, but the others had none. Pharmacists sometimes get training from pharma companies on their products and when and where services were commissioned within that pharmacy. So most are saying they would turn to local smoking cessation services if they needed advice, or simply refer the patient to them. But very interesting there that, you know, that the tools aren't there amongst these healthcare professionals to actually take action at the point of contact with the patients. Just going to whiz through the key points then. So first point, smoking still seen very much as a priority, fundamental in the drive to improve health inequalities, but barriers are multifold, you know, time pressures, lack of expertise, fragmented service position, lack of funding. They feel okay about talking to patients about smoking, and those patients tend to expect and accept such conversations. They get frustrated when patients are referred on, but they don't get any feedback about the referral. GPs severely limited by time, sometimes will rely on the practice nurse to have those conversations, and they can sometimes be quite vague about what is available to their patients in terms of external support. Regular conversations had by practice nurses, but again, they're pressed for time and don't have a lot of training. Mental health patients require different management, primary focus on safety when in crisis, and then something that's very tailored and flexible in terms of the approach to quit support. Pharmacists experiencing a new positioning in the minds of their communities, greater visibility of their services, and see this as a real opportunity to work in partnership with patients and provide a more holistic care. Vaping is a hot potato still, very different attitudes in terms of using it as a route to quitting. People calling for more evidence to its safety. Certainly a trend to favour a cutting down message, particularly where quitting isn't an option, but also as a preparation for quitting. And the landscape of service provision so fragmented, and a very wide range of familiarity and knowledge about it in the areas. People would like to offer in-house provision. It's seen by many as the optimum model, and as is ultra-local. And the pandemic has brought with it changes for good and bad, and that everybody that we spoke to is still working with the backlog of stress caused by the pandemic. So I'm sorry, I've probably taken far too long.
No, that was excellent, Sonia. Just before we move on to Alex, I just wanted to pick up one thing. James Gillis is rightly reminding us in the chat that in previous webinars we've talked about the perception of smokers towards healthcare professionals and how that might impact on their interaction with those healthcare professionals. And you alluded to in your talk about, you know, I come with my ingrown toenail and they make it about smoking. Is there anything else you would add to that to kind of enrich our conversation?
Well, I think that when you ask people where could they go for help, then GPs are typically the first person they speak to, or they speak about, but they have different natures of relationships with their GPs, and there are some that were saying yes, I'd very much talk to my GP about it, and some that are like no, because I get blamed, you know, every time I go it's about my smoking, you know, they're just nagging me, you know, I don't want to talk to them. Pharmacists possibly have a less baggage attached to them, and as we say, with this new positioning, and people talk a lot more about going to talk to the pharmacist than they ever did in the past. I think the pandemic seems to have changed quite a lot about that, and I think because people are aware of that, they feel that that pharmacists are a good option for approaching regarding quitting.
Yeah, that's interesting, and that's been quite a live issue over the weekend as well, with comments from Secretary of State about antibiotics, among other things. Thanks, Sonya. We'll come back to you in the Q&A, and I'll hand over to you, Alex, to give us a kind of GP perspective and GP response.
Okay, well, yeah, if you can manage with slides, that'd be great. I'm a GP, and I've been heavily involved in smoking cessation for about 20 years now. And my great passion really is trying to teach, I say trying, to teach GPs and trainee GPs smoking cessation. And so I have a fairly decent hands-on insight into the genuine knowledge, not what they put down on forms, as their claimed knowledge, but their actual knowledge around smoking cessation. And I'm afraid you need to brace yourselves for the next couple of minutes. So we can go on to the first slide. Yeah, as Sonya said, all should be rosy, shouldn't it? Because smoking is regarded as the priority in terms of healthcare among all healthcare professionals, and certainly among GPs. It's extremely important. It's a priority. It's fundamental. These are the words that you've already heard. I'm afraid we've got the next bit of the slide, which is this bit, and it's but. And there are fundamental misunderstandings around smoking cessation, I'm afraid, through the vast majority of GPs and GP trainees in the UK. And it's not their fault. Let's be clear about this. I'm not here to blame my colleagues. It is very much part of the lack of education around smoking cessation, and I'll come to that later. But the result is that we've got this tendency among GPs to feel that it's up to the smoker to stop. So what they're tending to do, in fact, is waiting for someone to come to them, asking for help, for them to be proactive, rather than actually trying to help show what can be done. You get advice to stop rather than how to stop. I think that's probably the biggest mistake that GPs make, and probably many other health professionals, that, you know, shaking the finger, or more gently just saying this is really bad, telling them reasons why they should stop, but not actually facilitating how to do it. And you've got these attitudes like it's not a medical problem. And again, that is such a mistake to go in with that attitude, because if you just think it's something that they're doing, smokers are doing, that they can sort out, it's not going to happen. The evidence is very clear that the best way to stop smoking is with support and treatments, which clearly are medical. They are medical treatments. Nicotine replacement, varenicline, if you could get it, and bupropion are medical treatments, which GPs should certainly understand, but I'm afraid just don't. They say it's not my job, I've got lots of other things to do. Well, frankly, you know, GPs are paid by managing long-term conditions, and I think it's something like 17 of the 19 long-term conditions that GPs manage are smoking related, unbelievably. So we're good at giving advice that it's a bad thing, but we're not telling people how to manage smoking, and don't really see smoking as a medical problem in its own right. I think that's such an important thing. So we don't have consultations about smoking, which we should certainly be doing, but GPs would argue that they're not trained to do it. So it's not surprising that doesn't happen. They say smokers don't want to stop, it's a lifestyle choice, all these, you know, it's such a wind up to hear these things, and saying all they need really is willpower. I think if you look at it carefully, when you see doctors talking about smoking, they're quite comfortable doing it relating to medical problems. So someone comes in with a chest problem or heart problem, very easy to say, well, obviously the smoking is contributory and you need to look at stopping that. But it's not the helpful way of doing it, talking about smoking may be related to a medical problem, another medical problem, but smoking in its own right. They need to be able to take on a smoker about their smoking, and they don't feel equipped to do it. So they're not comfortable. So it doesn't happen. That's the real problem. And as far as mental health problems are concerned, patients with mental health problems, there are so many misconceptions among health professionals generally, but particularly among GPs, that, I mean, for example, people with mental health problems don't want to stop smoking. You can't help them. It makes their mental health worse. None of these are true. They do want to stop smoking on the whole. They do respond well to treatment and support. And of course, their mental health actually improves when they stop smoking. So these are very simple things which I'm afraid GPs get very wrong a lot. Next slide, please. So, yeah, you've already heard that as far as GP is concerned, time is the biggest barrier. Well, yeah, that's what you hear. And of course, GPs are horrendously time pressured, no doubt about it. But time, I'm going to get philosophical now, time is a perception. And you feel time is against you if you don't know what to say or do. But if you've got simple way of doing things, simple tools like very brief advice, which we'll come on to, you can actually manage smokers in a more quick and more effective way than they're doing already. But if we can go to the rest of the slide, that just isn't happening. And the reason for that is lack of training. I mean, education, I believe it's been said before. But, you know, I think people in surveys don't appreciate how bad the lack of training is. People report being trained when they just haven't been. They may interpret having been told the evils of smoking as training in smoking cessation. But actual core training in how to deliver evidence-based treatment and support just isn't there. It's not there at an undergraduate level, and it's certainly not there as a postgraduate level. And of course, yeah, I forgive any health professional for being confused about local stop smoking services, because obviously they've been in great turmoil over the last few years. But there isn't a fundamental understanding about what the services do and how you access them, not even who they are, what they can offer, and how prescriptions work, and so on. And VBA, which is kind of my hobby horse, which is something designed specifically for UK GPs, actually, which is to deliver really very quick intervention in less than 30 seconds on how to stop smoking, and signposting and guiding them in that direction without even asking them if they want to stop, asking if they're interested in stopping what they've done before. None of that. It's nothing to challenge the addict. It's just getting them information to get them towards an evidence-based quit attempt. I'm sorry, that's just not happening in UK general practice, apart from really a tiny minority of practitioners who have been trained and have taken it on board. Confusion around prescribing, of course, comes from lack of training. If you don't know what the drugs are, how do you use them? They have no idea, frankly, how to use nicotine replacement. And vaping, well, again, let's forgive people for being confused. I think to sum it up in terms of knowledge, the knowledge of GPs around smoking cessation is general knowledge. It's not trained knowledge. And you've heard from Sonya that smokers go to GPs expecting that they'll know stuff about smoking cessation. That's a reasonable expectation. It's not there. And so when they go, they will tend, I'm afraid, to be given quite very poor, let's face it, information around these things based on general knowledge rather than on expert training. That's really what has to change more than anything else. A couple of other little things, well, hardly little, but there is this barrier around I'm going to upset the patient. And that's a big reason for not trying to engage a smoker in talking about smoking cessation. They don't think that they want to go there. And yes, as Sonya also said, it leads to box ticking. You know, we have this QOF, quality outcomes framework, and we are measured on delivery of smoking interventions, and the interventions we're delivered on are establishing smoking status and referral or advice on providing stop smoking support and treatment. It's easy to tick those boxes without doing much, and I'm afraid that is almost the norm, dare I say it. So I think what we need to do, because this has been very negative, but you've got to be realistic about this, we have got to lobby hard to get smoking cessation as part of routine undergraduate training. You can do it in a day. And I know a lot of lobby groups for disease areas say, well, you know, I couldn't get my day in 5 years training, but for goodness sake, smoking cessation, which is so fundamental to the nation's health, even with a 14% prevalence of smoking, it deserves at least a day in undergraduate training, and that just isn't happening. And particularly GPs, but frankly, all hospital doctors should at least have good training, which has been tested in very brief advice, so that at least smokers will routinely know how to go to get decent support and treatment. And that will mean that, you know, if everyone's singing from the same hymn sheet in my utopia, then you've got people hearing the same message over and over again, and they will understand that support and treatment can make an enormous difference to smokers. And I think the final point I've got here is there aren't dedicated appointments for smoking cessation in primary care from GPs, not proactively. And that's because they don't regard it as a medical problem, and they don't feel they've got the capabilities to deliver advice on support and treatment. So I'm afraid I haven't painted a very rosy picture, but at least I hope that gives people, maybe commissioners out there who are listening to this, an understanding of what is needed to really help the groups of society who need the most help in terms of health inequality by the intervention which makes more difference than any other, which is smoking cessation.
Fantastic, thanks, Alex. Hopefully we'll have time to come back to some of the very rich questions in the queue in the chat. But before we get there, Darush, I'd hand over to you to give us the pharmacist response. I think pharmacists are like the profession of the moment in some ways. So over to you.
Thanks, Hazel. Am I able to share my screen, or maybe you could put the slides up?
Hopefully. Yelena, have you got Darush's slides? Do you want to put them up if that's easier?
Or give me permission to share, because at the moment
we've not given you permission to share. That's no good. Let me see if I can do that.
Okay, thanks.
Make you a presenter.
There
You should have permission now, Darush.
I can share. Yes. Right. You can see my
I can, yes.
Yeah. Perfect. So yes, pharmacists are the profession at the moment. I think they're amongst other professionals, but I think ever since I qualified as a pharmacist back in 1996, things were changing. More pharmacies were developing consultation rooms within their pharmacies, and they're doing far more than just doing prescriptions and over-the-counter sales. But Alex was talking about smoking cessation, medicalising it more, and that's something that I think ever since I've been working in respiratory since 2014, that's exactly what I talk about, is treating tobacco dependence as a chronic relapsing long-term condition that generally starts in childhood. But just to say, there's a lot going on in community pharmacy at the moment. In the last few years, all pharmacies in England have become healthy living pharmacies. So you'd have counter assistants as health champions who would have done some training to become health champions, and that's really looking at how we can do things like very brief advice, but not just for smoking cessation or treating tobacco dependency, but also for weight management and health checks. And a lot more pharmacies are getting involved with offering, for example, vaccinations, as we all know. And these days we've got this message around pharmacy first before, you know, going to visit the GP practice. You know, go to see that skilled clinician within the pharmacy who can offer that sort of support. And sometimes NHS 111 and GP practices are doing direct referrals to community pharmacy as well. So far more than just medicines experts, we become long-term condition experts as well. So my background is community pharmacy, and I'm really passionate about it. The good thing about what we say about pharmacies is that you're never more than 20 minutes away from a pharmacy as well, and we don't generally have to make appointments, but you do sometimes for some conditions. This was pre-pandemic, was one of the health promotion zones in a pharmacy I was working in. And just to say that smoking cessation was a bread and butter service that we're offering in that particular pharmacy. But then the service was decommissioned a few years back. And I found smoking cessation or treating tobacco dependency was a sort of bread and butter service for a lot of pharmacies across the country, actually, and it became part and parcel of what we did. So very brief advice, as well as offering the intensive support on a one-to-one basis. So I'm currently working across northwest London, but also I was covering north central London, and I do quite a lot of training and support. And the good news is there's still quite a lot of pharmacies offering that intensive support as well as doing the very brief advice. But a lot of pharmacies are now working in GP practices as well, become prescribers, which is good. And a great opportunity for us is, for example, when we're offering very brief advice, we could do that during, for example, when we're giving vaccines. I can remember there was obviously a big Quit for COVID campaign, which was great. And one of the key messages we're trying to incorporate into the very brief advice is that you're 5 times less likely to get flu if you're a non-smoker, or you're twice less likely to get pneumonia if you're a non-smoker. So trying to encourage people to go smoke-free as part of that 30-second approach, I thought was really, really good. And community pharmacy has got obviously that opportunity to encourage more people, and also we're reaching the people that we need to reach, which is people of lower demographic groups as well, which is fantastic. Just to give you a bit of a flavour as well of another service that pharmacies have been offering for a while, is something called the New Medicine Service. So I know when I'm doing respiratory work, a lot of the work I'll be doing will be around inhaler technique optimization. And if somebody's coming in for their inhaler technique check, they've got a new medicine in a new inhaler, it's again a great opportunity to highlight that, for example, if a person was to stop smoking, that their medication will become more effective, basically, because inhaled corticosteroids, or those preventative treatments, are less effective if you're a current smoker. So having that knowledge about drug interactions and smoking is an important part. But just knowing that actually any intervention I would make as a pharmacist, and my colleagues would, we know that stopping smoking trumps anything we could do when it comes to helping that breathless patient as well. And it's great, of course, for their mental health too. One of the things, though, I was finding is a lot of the respiratory related services was declining in community pharmacy, but now they've started to rise again, because we need to make sure that the pharmacists are reimbursed for some of the services that they're offering. The good thing is, like, community pharmacies now can, when inhalers are being brought back and recycled, we're trying to do a big push around the planet. Of course, we all have one planet, and we want to save that planet. So that whole thing around indoor and outdoor air pollution, as well as safer disposal of inhalers, is a big part of these healthy living pharmacies now. So maybe tapping into that a bit more is important for those pharmacies who feel that they're not able to offer that intensive support. At least if they can offer the very brief advice and also bring it in with that indoor and outdoor pollution, that would be good. The other thing just to say is that I know the pharmacy doors have been open for during the pandemic, which was great, but it's trying to get back into doing some more health promotion, like things like knowing your carbon monoxide readings. This is something that was being done quite a lot in pharmacies. But this particular service, which is paid, this advanced service, is not really kicked off yet. So this is something where patients are discharged from hospital and they're getting follow-up support in the community pharmacy. I know this was piloted, but I haven't seen many areas actually delivering this extra additional service. And just finally, final slide, which is just to highlight that a summary slide really is just the evolving role of pharmacy has become a lot more holistic. We're really trying to actively think about putting ourselves in the patient's shoes and what matters to the patient, and bringing in all of these things around structured medication reviews, which always raises smoking. New medicine service always raises smoking, and that pharmacy first service around patients who are being directed to community pharmacy. Smoking normally gets brought up there. So it's more than just anyone browsing NRT. And I think there should be more around also having that upskilling, because I think a lot of community pharmacies are being left out of upskilling and training around these sorts of areas. So that's something that we should focus on. That's my slides.
Brilliant. Thanks, Darush. Thanks. If you stop sharing, and then we'll, and if Sonya, if you want to come back too. So we've got 10 minutes to have a bit of a chat. It's been quite lively in the chat bar, so we probably won't cover everybody's questions. But I wonder if it might be worth starting kind of with some thoughts about, most of the people who are listening here are going to be working in local authority stop smoking services, working in the NHS, working at regional level. And some of them will maybe be in primary care and in pharmacies and GPs, but I'm guessing that largely our audience is not there. And what they want to do is they want to work out, how do we galvanise our primary care partners to play a bigger role in getting more people to stop smoking. So I wonder if I could kind of have your kind of top reflections on how our audience could best engage. So there's been some stuff around, connecting people with the training, feedback loops from stop smoking services where referrals are made, commissioning into primary care in terms of commissioning pharmacy services. What do you think it is that can help make a difference within the parameters that people listening are operating under? Maybe start with you, Alex, and then.
Yeah, well, I've only been doing this 21 years and I still don't know the answer. I mean, it really is the $64,000 question, and it's engaging, but I think fundamentally it is, I'm afraid, education, because the problems come from attitude. And if you're not positive towards helping people stop smoking because you don't understand how to deal with the problem, then it's pretty much a non-starter. So I would say it's about trying to get training, basic training. It will take 2 or 3 hours of training minimum to understand smoking cessation properly, but that is what's needed. And the thing is, it changes people's attitudes and it also changes people's practices. But I've seen so many iterations of, let's introduce this pathway or this advice to be given, but if they don't understand what really is available, what it does and how it works, then it isn't delivered, and it's certainly not delivered properly. So yeah. I'm sorry to be, there's no quick fix on this. It has to be proper training, but it can be done late. You can teach old dogs new tricks as long as they're simple tricks. And the good thing about smoking cessation, because there are good things, is they are simple tricks.
Yeah, it's not complex.
And, so that's what they should be focusing on.
Darush, would you add anything to that from a pharmacy perspective?
Definitely, yeah. Because I think my role is because I'm working now with med management teams and across integrated care boards, and one of the things that's powerful is data. So in respiratory, there's a lot of incentives going to GP practices at the moment. We call it as part of the NHS long-term plan. But one of the things I'm finding is high doses of inhaled corticosteroids, for example. There's a local prescribing incentive scheme. A lot of people think it's just purely down to maybe poor inhaler technique or patients not taking their medication, but they're not realizing actually that smoking obviously makes these medications less effective. So it's linking it in with, there's quite a few different metrics that are being looked at. One is around overuse of a reliever inhaler, for example, but you can name this in any long-term condition because smoking's linked. And if we could say, look, we can help your local area with regards to improving some of these metrics, and treating tobacco dependency is a key element of that, and we can incorporate some of this training in, as well as I find sometimes if you're just doing a pure smoking cessation training event, you might not get pick up, unfortunately. I agree with Alex, it would be great to have a dedicated smoking cessation training event, but I'm finding I'm having to mix it in with a bit of COPD and asthma education, and then I'm throwing in a lot around VBA, and as well as prescribing of treatments. So it's almost like you have to almost trying to be innovative and think, where can I get that audience of GPs or nurses or pharmacists?
And who should be delivering this training? We want them to find. In some of the chat has been talking about. I think that might have been pointed at GPs. Not seeing sort of smoking service staff as kind of credible. Not necessarily valuing the information that they give them. Is it the Stop Smoking Service who should be delivering this, because that's probably the most practical way for most areas to be doing that, or are there other, does it need to be a different messenger?
I'm afraid I've got to put my hands up. GPs are difficult. They really are a difficult audience. I mean, I'm a GP, so I've got a big advantage, and Stop Smoking Service people can be the best in the world, but they are starting at disadvantage with the arms folded at the beginning of the talk. We all know that feeling. And, trying to get through as someone who's not a GP is hard. But, there is online training available. There's good VBA training available through the NS. PCC, I can't even remember.
NCSCT.
So yeah, I mean, that's putting people onto that training would be very good. It's grossly underused. It's free for all health GPs in the UK. It's very, very good training. It's quick and it gives them PDP. So let's try and get them onto that. We'll
get the link round as well. Hopefully people will be familiar with it, but we'll circulate that link. I mean, Sonya, from your interviews, what do you think is going to be what's credible, do you think, for this audience? What do we need to cut through to get them to listen to the training that's out there and change their practice?
Well, we didn't necessarily talk a huge amount about training. It was just something we briefly covered to understand what had been there. But I think it's just, well, there's two things, aren't there? There's the understanding how to deliver support themselves, but also even just the basics of, if they're not commissioned to deliver that, how to get it's the simplicity of pathway and understanding what they have to do, what happens at the end of that pathway, and how they can perhaps close the loop and get that feedback about it.
Can I just address one misconception from GPs about prescribing? They're independent prescribers, for goodness sake. They can prescribe anything that's licensed, which is good for their patients. And, the arguments for smoking cessation treatment effectiveness are second, literally, to none. They are the most cost-effective interventions that we can prescribe. So the idea that they're not allowed to prescribe them is a nonsense, and frankly, borders on legality. So this is the message I give to GPs. Where is your responsibility? It must be for your smoking patients as a practitioner.
Darush.
Yeah, just a quick one from me, just to say that there's also, because of the way the structures are changing across the integrated care boards, what I'm finding, I'm getting a good opportunity to talk at GP forums, where I get 10-minute, 15-minute slots, and can capture a good audience there. I do think it matters who does talk. It could be somebody from the Stop Smoking Service, but it has a bit of clinical know-how as well. I think it depends on the individual. It's not always has to be a GP to GP. I find a clinician to a GP can work, but also a knowledgeable stop smoking person within a service as well would be fine to get that message across to.
In our dying moments as well, I'm quite interested in the kind of growing role of the pharmacist, and I think the interesting stuff which Sonya was reflecting on smokers, when you first ask them when they would go for support, kind of GP is front of mind, but actually unpacking a bit more about what their kind of contact is with healthcare professionals is much more routinely pharmacists. And obviously pharmacists have a kind of volume contact, I suppose, with the population, like you see a lot of people. I mean, GPs do too, clearly. But the kind of flip side being that specialist stop smoking services, clearly as a dedicated service with dedicated expertise, tend to get better outcomes on the smoking cessation side. Could you perhaps talk a bit, Darush, about that balance there between the kind of volume of people versus that, specialist service that you might see in a local authority commission service or whatever.
Yeah, I mean, once you've got a dedicated support service, you have a patient group direction for bupropion or varenicline when it's available again. I think the more you add on the tiers where there's a bit of extra incentive, I think, of course, the upskilling obviously goes up more. They'd have to do various online modules, which even if they go through the Centre of Pharmacy postgraduate education, it will still link back to the NCSCT when they do that training. And so it's, yeah, so all in all,
we're going to have new services, as you were saying, coming online through the long-term plan. So even if they're not being commissioned by local authorities, it feels like there will be an upskilling in pharmacy around smoking cessation, which creates some opportunity.
Yeah, and I think the memories are still there for some, as in it was only a few years ago they were running the service. It was decommissioned, but they'll need some refresher type of training, you know. So I wouldn't say they've all gone, they're still out there. We just need to try and re-engage.
Thank you so much, all of you. There's so much more we could talk about. I think in summary, there continues to be a massive challenge in engaging primary care professionals to really play the role that they could be in helping smokers stop. But there's opportunity in our kind of new structures around it, as you were saying, Darush, in the integrated care system structure, the coming on board of new services through the long-term plan. We have resources that we can push out to GPs and to pharmacists that we need to kind of maximise those opportunities. And so really look forward to hearing back from everybody on this webinar about how it goes, you know, reaching out to GPs and to pharmacists and seeing where we can get to with encouraging them to play that bigger role. Thank you so much to Darush and to Alex. Thank you, Sonya, for your fourth in your epic series of webinars. We'll be sending out an evaluation after this event about this event and all of the previous ones as well. Really keen to get everyone's feedback, and hopefully we can come back again perhaps in 12 months' time with some more insights and have some further discussions. So thank you, everybody, and have a good morning.
Thank you.
Okay, thanks. Bye.